Imagine going to the doctor with a single painless white spot on your skin.
Just one little spot.
Right. And one doctor takes a quick look and tells you to go home, use some moisturizer, and, just wait for it to fade on its own.
Which sounds pretty harmless.
It does. But then another doctor looks at that exact same spot and tells you that without aggressive, immediate steroid treatments, your body's structural anatomy will literally begin to fuse together.
It's terrifying. And it is the absolute definition of diagnostic muddy waters.
It really is. Welcome to the deep dive. Today, we are wading into a diagnostic landscape that is high stakes and, honestly, incredibly murky.
Yeah, we're looking at two conditions that, to the untrained eye anyway, can look almost perfectly identical. They both present as patches of white skin.
But they behave in radically different ways. We took a massive stack of clinical guidelines, dermatology journals, and patient fact sheets, and distilled them down to solve one very specific medical mystery for you.
Right, because the consequences of mixing these two up are just enormous.
Exactly. So our mission today is to answer this. How does a clinician differentiate between the early white patches of lichen sclerosus, which is often called LS, and post-inflammatory hypopigmentation, known as PIH?
And, the reason you should care about this is that misdiagnosing these two can lead to completely devastating outcomes.
Because one of these conditions essentially heals itself with time, but the other can cause permanent, irreversible architectural damage to your body if it isn't caught early.
Yeah.
Okay, let's unpack this.
So to really understand how a doctor tells them apart, we first have to look beneath the surface. Like, what are these conditions actually doing at a cellular level?
Mechanically speaking.
Right, mechanically. Before we can even begin to spot the differences in an exam room, let's start with the condition that heals, which is post-inflammatory hypopigmentation, or PIH.
The sources essentially describe this one as the aftermath of a traumatic event for your skin.
That's a really great way to think about it. PIH is, well, it's the quiet after the storm.
So it happens after the damage is done.
Exactly. It happens after your skin has been through some kind of intense inflammation or physical injury. This could be a severe sunburn, a bad flare-up of eczema, psoriasis, or even, a cosmetic laser procedure that was just a bit too aggressive.
So the skin gets angry, the alarm bells go off, but how exactly does that lead to a white patch? I mean, what is the actual mechanism shutting the color off?
It comes down to a biological shock to your melanocytes. These are the specialized cells residing at the very bottom layer of your epidermis.
The pigment factories, basically.
Yeah, right. You can think of them as little factories producing melanin, which is the pigment that gives your skin its color. They have these long branch-like arms called dendrites.
Okay.
And those dendrites reach up and hand off packages of pigment to your regular skin cells. But during an inflammatory event, the chemical chaos in the skin essentially damages those factory delivery lines.
So the melanocytes get stunned.
Yeah, exactly. They might drop their pigment or their arms retract, temporarily shutting down production entirely.
But the melanocytes aren't completely wiped out or dead, right?
Usually no. They are still physically present down at the basement membrane of the skin. They just aren't producing or delivering melanin effectively anymore.
And the result is a localized decrease in pigment.
Right. The skin in that specific area becomes lighter because the supply chain has been disrupted.
Yeah.
Now, contrast that with the mechanism behind lichen sclerosus.
Yeah, LS is a totally different beast. The medical literature classifies it as a chronic inflammatory dermatosis, but what really stands out is the strong suspicion of an autoimmune component.
Which changes everything.
It really does, because researchers have found that a lot of patients with LS have autoantibodies attacking something called extracellular matrix protein 1, or ECM1.
And that is a crucial distinction. In LS, the immune system isn't just reacting to an external injury like a burn or a rash. It is actively turning against the body's own tissues.
So it's an inside job.
Exactly. ECM1 is essentially the biological glue. It's the scaffolding that maintains the structural integrity of your skin and your blood vessels.
Wow.
Yeah, when your immune system produces antibodies that specifically hunt down and attack that scaffolding, the tissue begins to fundamentally break down.
I noticed in the sources that this autoimmune attack doesn't seem to happen uniformly across the population either. Like, there's a very specific bimodal age distribution.
It's a fascinating pattern.
We see it most commonly in postmenopausal women, but also in prepubertal children. Is there a reason it targets those specific ages?
It heavily implicates hormones, specifically estrogen. Both prepubertal girls and postmenopausal women are in what we call a low estrogen state.
Okay, so less estrogen means higher risk.
Right. Estrogen doesn't just affect reproduction. It plays a massive role in modulating the immune system and maintaining skin thickness and barrier function.
Oh, that makes sense.
Yeah, when estrogen levels are low, the skin is physically thinner and potentially more vulnerable to this kind of localized autoimmune misfire.
And while LS can show up anywhere on the body, which we call extragenital LS, it most commonly attacks the anogenital region.
It does.
So, thinking about how to visualize the difference between the two, is PIH essentially like a printer running low on ink after a really bad paper jam?
Oh, I like that.
Like the printer itself, the physical structure is completely fine. The jam has been cleared, but the image coming out is just faded because the ink cartridge was disrupted.
Yes.
Meanwhile, lichen sclerosus is like the paper itself being fundamentally altered. It's not just missing ink. The immune system is chemically treating the paper, breaking down its fibers and turning it into a completely different material.
That analogy captures the mechanics perfectly. PIH is a disruption of the ink supply. LS is an active destruction of the paper.
Which brings us right into the exam room, right?
Exactly. Because if the paper itself is changing, it's going to look, feel, and behave differently when a clinician is actually trying to make a diagnosis.
Right. So patient walks in with a white patch. How does a doctor tell them apart without immediately resorting to, like, really expensive tests?
Well, the first step in any medical investigation is the patient history. A clinician will always ask, what happened to this area previously?
Right. Looking for clues.
Exactly. For PIH, there is almost always a history of an inflammatory event, a burn, an infection, a chemical peel.
Though it's worth noting that patients often just forget. I mean, a mild eczema flare-up from 6 months ago might not even register in someone's memory,
Yeah, that happens all the time.
which makes relying solely on history a bit dangerous.
Human memory is definitely fallible. That's why we look at the current symptoms. What is the patch doing right now? PIH is generally completely asymptomatic.
So no pain, no itching.
None. It doesn't hurt, it doesn't itch, it doesn't burn. It's just a faded spot on the skin. Lichen sclerosus, on the other hand, can be agonizingly symptomatic.
Especially in the genital region.
Yes, patients often report an intense, unyielding itch, severe soreness, and pain. The skin is physically thinning out, which exposes the microscopic nerve endings.
Oh, making them incredibly sensitive.
Extremely sensitive.
But just to make a clinician's job even harder, if LS is extragenital, meaning it pops up on the shoulder, the back, or under the breasts, it can sometimes be completely silent, like no itch, no pain at all.
Which is really tricky. It forces the clinician to rely heavily on visual and tachyphar clues. Let's look at color first.
Okay, color.
You might think white is white, but dermatologists look for degrees of depigmentation. In PIH, we're usually looking at a partial loss of pigment.
So it's not totally blank.
Right. The patches are poorly defined, they have irregular borders, and they're lighter than the surrounding skin, but they're rarely completely devoid of all color.
Going back to the printer, the cartridge is low, but it's not totally empty. There's still a faint image.
Yes.
But LS patches are described clinically as a stark porcelain or ivory white.
Yeah.
It's a much more profound, opaque color change.
It is. But color can still be subjective depending on the patient's natural skin tone. So the most definitive clinical differentiator isn't the color at all, it's the texture.
We're back to the paper.
Exactly. If you close your eyes and run your finger over a patch of PSH, it feels exactly like the normal skin next to it.
Because structurally, it is normal skin.
Bingo. Unless the underlying condition, like eczema, is still actively flaring and causing flakiness, the surface texture is completely unaltered. The scaffolding is intact.
But early LS is different because of that attack on the ECM1 protein we talked about. The skin begins to show epidermal atrophy.
Right, it physically thins out.
And there's a very specific visceral description in the dermatology world for this. They describe the skin in LS taking on a cigarette paper appearance.
Yeah, that crinkled, finely wrinkled texture is a hallmark sign. Because the structural glue is dissolving, the epidermis loses its normal plumpness and elasticity. It becomes incredibly fragile.
That fragility is terrifying. I mean, the skin can easily tear or bruise from even the slightest friction.
It's awful.
And sometimes, tragically, when this appears in young children, the spontaneous bruising and tearing can actually be mistaken for signs of physical or sexual abuse. It just highlights how absolutely critical a correct and rapid diagnosis is.
It's a devastating situation that requires a highly trained eye to catch. And beyond texture, a clinician will also look at the shape and location of the patches.
Which provides a sort of geographic roadmap, right?
Right. PIH strictly follows the random shape of whatever the original injury was. If you had a splash burn from hot coffee, the PIH will look exactly like a splash.
But genital LS creates a very specific symmetrical pattern. Clinicians look for a figure of eight or a keyhole shape that wraps around the vulva and the anus in
Yes,
females.
that keyhole pattern is classic.
But why does it form that specific shape? Is the immune system somehow programmed to draw a figure eight?
It has to do with something called the Koebner phenomenon. This is a process where autoimmune skin diseases are drawn to areas of microtrauma or friction.
Okay, so areas that get rubbed a lot.
Exactly. The anatomy of the vulva and anus is constantly subjected to the friction of walking, sitting, tight clothing, and exposure to moisture.
So that stress acts like a magnet.
Precisely. This constant, low-level physical stress draws the autoimmune attack to those specific symmetrical areas, forming that keyhole shape.
Okay, so we have history, texture, and shape. But what happens when a patient comes in and they are stuck in a gray area? Say the disease is in its absolute infancy.
The really early days.
Right. The cigarette paper crinkling hasn't fully developed yet. The shape is a bit ambiguous. The naked eye just isn't enough to make a definitive call without guessing.
When the naked eye reaches its limit, clinicians pull out a tool called a dermatoscope. It's essentially a highly specialized magnifying device with polarized light.
So they can see past the surface.
Exactly. It allows the doctor to see just below the surface of the skin, moving from the macro to the micro level.
What exactly is a doctor seeing when they look at early lichen sclerosus through a dermatoscope?
It reveals a bizarre, chaotic, microscopic landscape. When examining early LS, they won't just see a flat white patch. They will see structureless, white-yellowish areas.
Which means what exactly?
It represents the deeper tissue beginning to scar. But more importantly, they look for specific clues called comedo-like openings.
Comedo-like openings. Wait, a comedo is a blackhead, right? Are they seeing acne?
Well, it visually resembles a blackhead, but the mechanism is different. In LS, these openings represent plugged hair follicles.
Oh, interesting.
Yeah, as the skin is under attack, it sometimes reacts by going into overdrive, producing excess keratin to protect itself. This hyperkeratosis essentially chokes and suffocates its own hair follicles.
Creating those distinct dark plugs.
Exactly, which are visible only under magnification. The dermatoscope might also reveal another critical clue, which is an erythematous halo.
An erythematous halo, meaning a red ring.
Yes, a faint red ring surrounding the white patch. And that red ring is a massive warning sign for a clinician because it indicates active inflammation.
So the immune system is actively working there.
Right, it means the immune system is currently on the march at the borders of that lesion. The war is actively expanding outward. You might also see sparse linear or dotted blood vessels.
Which are what?
They're a sign of the tissue trying to generate new blood supply to cope with the damage.
Wait, let me challenge this for a second. You said earlier that PIH stands for post-inflammatory hypopigmentation.
I did.
It's caused by inflammation, like a bad eczema flare. So wouldn't a dermatoscope also show that red ring of active inflammation in PIH? Why is a red ring a differentiator for LS?
That is a fantastic question, and it all comes down to timing. PIH is the post-inflammatory. By the time the skin turns white and the patient comes in for PIH, the fire is already burned out.
Oh, so the inflammation is totally gone.
Exactly. LS, however, is a chronic active forest fire. The center of the patch is white because it's already been destroyed, but the red ring on the outside shows that the flames are still spreading.
That makes perfect sense. So if you point that dermatoscope at a patch of PIH, you don't see any of this.
Absolutely nothing of the sort. And that is the beauty of dermoscopy. PIH lacks all of these chaotic features. Under a dermatoscope, PIH just looks like completely normal, peaceful skin architecture.
Just with less pigment.
Right. It simply has a faint, reduced pigment network. There are no comedo-like plugs suffocating the follicles. There are no structureless white or yellow patches of scarring. There is no red halo of an advancing army.
So the dermatoscope is incredibly powerful for confirming that the printer is just low on ink. But medicine is rarely a perfect science.
True.
Sometimes, even with dermoscopy, the picture is blurry. Maybe the patient has a history of trauma and an autoimmune disease. What happens when the clinical guidelines say the diagnosis is still uncertain?
When you absolutely cannot afford to be wrong, the guidelines mandate the ultimate tiebreaker, which is a skin biopsy. You take a physical sample of the tissue, stain it, and look at it under a microscope to see the cellular mechanics in action.
Histopathology.
Exactly.
Let's zoom all the way down to the cellular level. When a pathologist looks at a biopsy of PIH, what story are the cells telling them?
The story of PIH under a microscope is a story of a quiet cleanup operation. The pathologist will immediately see that the melanocytes are still physically present at the basement membrane.
They haven't been eradicated.
Right, they just aren't producing melanin. But the real smoking gun for PIH is the presence of something called pigment-laden macrophages deep in the dermis.
Let's break that down. What are macrophages doing with pigment?
Well, macrophages are part of your immune system's cleanup crew. The word literally translates to big eaters.
Yeah.
During that original inflammatory event, say the severe sunburn, some of the melanin pigment was damaged.
And it physically dropped out of the epidermis?
Yes, falling down into the deeper dermal layer where it doesn't belong. We call this melanin incontinence.
Oh, wow.
So those macrophage janitors come in and gobble up that stray pigment to clean up the mess. But they can't digest it easily, so they just kind of hold on to it.
So seeing these pigment-laden macrophages tells the pathologist, there was a battle here months ago, the pigment dropped, and the janitors are just sweeping up the debris, the war is over.
Precisely. Now, contrast that with a biopsy of early lichen sclerosus.
And this is where the research gets really interesting, because the literature notes that early LS histology can actually be difficult to interpret, which seems totally counterintuitive to me.
It does sound weird at first.
Right, because if LS is a destructive autoimmune disease, shouldn't it be blindingly obvious under a microscope? Why is early LS tricky for a pathologist to spot?
Because in early LS, the classic massive structural scarring hasn't fully materialized yet. The tissue is in a state of chaotic transition, but there are distinct microscopic red flags if you know what to look for.
Like what?
The first thing a pathologist will see is vacuolar degeneration of the basal layer.
Okay, vacuole degeneration. Let's translate that. Are we talking about literal vacuums or empty holes forming in the skin?
Essentially, yes. The cells at the very bottom layer of the epidermis start taking on fluid, forming tiny bubbles or vacuoles. As these bubbles form, the cells degenerate and lose their grip on the underlying dermis.
So the foundation is washing away.
Yes. And beneath that failing foundation, the pathologist will see a band-like lymphocytic infiltrate.
Lymphocytes, so T cells.
Exactly. A literal army of T cells lining up in a dense band just below the epidermis, actively attacking that ECM1 structural protein we talked about.
Wow.
And finally, you see the initial stages of something called the homogenization of collagen in the dermis, also known as hyalinization.
Hyalinization. How does that connect to the skin feeling like cigarette paper?
Well, normal collagen in your skin looks like a nicely organized, loose, wavy network of fibers, like a loosely woven sweater. It gives skin its bounce.
Okay.
In LS, the inflammation causes those individual fibers to fuse and melt together into a dense, solid, pink, glass-like mass. The loose sweater gets melted into a stiff plastic sheet. That's hyalinization.
So unlike PIH, which shows a quiet cleanup crew, an early LS biopsy shows an active, raging war zone. The foundation is failing, T cells are invading, and collagen is literally melting together. Which brings us to the ultimate question. Why does going to all this trouble matter? Why do clinicians need to analyze the patient's history, examine the texture, bring out a dermatoscope, and sometimes perform a surgical biopsy just to tell two white spots apart?
Because accurately distinguishing these two under the microscope dictates the treatment. And their treatments are total polar opposites.
Right. Let's look at the stakes here. For PIH, the clinical guidelines are very clear. It requires no aggressive treatment at all.
Because it's just the aftermath of an injury.
Exactly. It often resolves completely on its own over time as the melanocytes recover from their shock and wake back up. If a patient is really bothered by it cosmetically, a doctor might suggest gentle light therapy to stimulate pigment production or basic barrier creams.
But you would never, ever use heavy immunosuppressive drugs on PIH.
Right, but lichen sclerosus, that requires immediate serious intervention. The absolute standard of care is the use of ultra-potent topical corticosteroids like clobetasol.
Which are medications that doctors traditionally try to avoid using on thin genital skin because steroids themselves can cause skin thinning.
Oh, really?
Yeah, but in the case of LS, they are absolutely necessary to save the patient's anatomy.
Because you have to halt that army of T cells. You have to shut down the autoimmune fire.
Exactly. If you don't treat LS aggressively and early, the consequences are severe. The unchecked inflammation will cause irreversible anatomical scarring.
The sources mentioned complete resorption.
Right. Yes. In women, this can lead to the complete resorption, the literal erasing of the labia minora. It can bury the clitoris under dense scar tissue. It narrows the vaginal opening, making intimacy excruciatingly painful or entirely impossible.
And in men.
In men, it leads to severe phimosis, where the foreskin fuses to the glands, and the scarring can narrow the urethra so severely that simply urinating becomes a medical emergency.
It is essentially the body erasing its own normal architecture. And
Yeah,
beyond the functional and emotional devastation of that, there is a very real, quantifiable medical risk.
a huge risk.
The research clearly states that untreated or poorly controlled genital LS carries about a 5% risk of developing into squamous cell carcinoma, which is a serious type of skin cancer.
That is the ultimate stake. Chronic, unchecked inflammation forces cells to constantly repair themselves, which eventually leads to DNA damage and cancer.
But PIH won't do that.
No, PIH will never turn into cancer. It is entirely benign. LS has a dedicated pathway to malignancy if left to run rampant.
So let's trace the journey we've just taken. We started by defining our contenders at the cellular level. PIH is the passive fading of ink after a trauma shuts down the melanocyte factories.
Right.
Lichen sclerosus is an active autoimmune attack that destroys the structural rebar of the skin.
From there, we looked at how a clinician acts as a detective. They check the history for past injuries versus intense, unyielding itch. They look at the location, random splash shapes, versus that highly specific keyhole pattern drawn by mechanical friction.
And most importantly, they look for that delicate cigarette paper crinkling that betrays the thinning of the skin.
Exactly. And when the naked eye isn't enough, we zoom in with dermoscopy, looking for hyperkeratinized plugged follicles and those red rings of expanding inflammation that give away early LS.
Contrasting sharply with the peaceful, normal architecture of PIH.
Right. And when all else fails, a skin biopsy acts as the final judge, looking for those pigment-laden macrophage janitors sweeping up melanin and PIH versus the invading T-cell army bubbling basal layers and melting collagen in early LS.
All of this complex deduction serves one purpose, ensuring the patient gets the right treatment. The gift of time and patience for PIH, or the critical structure-saving intervention of ultra-potent steroids for LS.
It's so vital.
And this matters to you, the listener, because if you or a loved one ever notice unexplained white patches on your skin, you now have a fundamentally deeper understanding of what's going on behind the scenes. Knowing that the texture of the skin, that crinkling, that unnatural fragility is just as important as the color empowers you. It empowers you to advocate for yourself in the exam room. You can say, I know this looks like a faded spot, but the texture feels different to me. Could we look closer with the dermatoscope?
It's about being an active, informed participant in your own healthcare, rather than just a passive recipient. But beyond the clinical takeaways, there is something deeply profound about what these two conditions teach us about the human body.
What do you mean?
Well, our skin is, in many ways, a living, breathing diary. Post-inflammatory hypopigmentation is just a faded memory of a past injury. It's a passive fading of ink on a page that remains perfectly intact.
But lichen sclerosus represents something much more complex and slightly unnerving.
It is the immune system actively rewriting the script. It is altering the very extracellular matrix, the foundational connective tissue of our bodies, turning soft, living tissue into rigid, scar-like parchment.
Right before our eyes, on the very surface of our bodies.
Exactly. And it leaves us with a compelling, almost unsettling question to ponder. If an autoimmune misfire can fundamentally alter our physical architecture in plain sight on our skin, what other invisible microscopic structural changes is the immune system making deep inside our bodies, in our organs, our blood vessels, our joints, that we haven't even learned how to read yet?
We started this deep dive talking about the comforting certainty of a broken bone on an X-ray, the safety of seeing exactly what is wrong. But the skin shows us that the body's internal wars are rarely that simple. Sometimes the most profound and dangerous changes happen right on the surface, just waiting for us to learn how to see them.